To do harm with say, Botox, you probably need about 30 100-unit vials injected intraperitoneally to do any damage. So it's not going to do any serious damage. Look, this is one of the most toxic substances known to man, but toxin is dependent upon dose. You can kill yourself with water if you drink enough of it, but you couldn't afford an overdose of toxin unless you sold your car or probably your house. There is no such thing as a bad toxin, but we also all know, those of us who've used more than one or two toxins, they all have their individual little niceties. There's many variables, and I use my 6D technique. It's highly unlikely that the patient has had sufficient effect on the toxin to make a side effect occur. 9 times out of 10, you've put the product in the wrong place, or you've chosen the wrong product for the indication, and there's too many injectors are looking to shift the blame.
Welcome to Inside Aesthetics, the world's leading podcast for cosmetic practitioners and business owners.
Our podcasts are aimed at medical professionals and should not be used to make medical, legal, or financial decisions. You should get an appropriately tailored piece of advice from a professional in your country.
To show your support and stay up to date with our latest episodes, click the follow button if you're listening on Apple Podcasts or Spotify. And if you're watching our episodes on YouTube, hit the subscribe button as well as the bell icon.
If you're interested in joining our online community, being a guest on the podcast, or would like to work with us, all of our contact details are in the show notes. And now, let's jump into today's episode.
Hey guys, welcome to another episode of Inside Aesthetics. Now today is one of my favourite ones. It's another Tox Talks episode.
It's the deep and dirty nerd talk.
Yeah. I love it. Now our special guest today is Dr. David Eccleston. We had David on back in episode 263 where he was talking about a new toxin at the time called Nuceiva, also known as Jeuveau in the United States. Yep. This podcast is all going to be about complications of toxins and some of that more nerdy, geeky stuff, but also, it's how to get the best out of our toxins as well.
Yeah. I mean, there's so many toxins now on the market. It's like every week there's a new one. So I think that having these sorts of discussions to help our listeners get, better understanding how to get the most out of them, how to avoid the pitfalls, it's more important now than ever, really.
Yeah. Now, this is chapter 12 of our Tox Talks. If you've missed all the other ones, go and listen to them. We won't be going into one of the specific issues with toxins, which is immunogenicity and resistance. We've done that to death in other episodes. So check out episode 176 with Stefania Roberts and Neve Kordoff. That was a good one.
The great debate.
Yes. Yeah, the great debate. So we won't touch on those sorts of complications, but everything else we'll cover in this one.
Everything else is fair game. Now, there's something special about this episode, Jake, isn't there? Because it kind of, coincides with our new app. So what's going to be happening here? Yeah,
so here in part 1, this is available on all of your normal podcast apps, Apple, Spotify, YouTube, etc. And we'll be talking about some more softer skills, consultation skills, David's background with toxins. And then in part 2, that will live in our new exclusive episodes area of our new app. Now, let's reintroduce David, all the way from Birmingham, the UK. First of all, David, how are you today? Thank you for joining us so late. We really appreciate your time.
No problem. It's great to be here with you again. I did a webinar with the Aussie team this morning at 6 a.m. UK time, so it's been rather a long day. So forgive me if I fall asleep halfway through.
Oh, Birmingham, isn't that where the Peaky Blinders are from?
Exactly.
Absolutely.
Were you one of those guys, Dave? Was that you in the young years, part of that
well,
crew?
I must admit, I do have a Peaky Blinders cap. They were called the Peaky Blinders.
You go.
They used to keep a razor blade in the brim of their cap, so they could use their cap to slash their opposing gangs. They'd take their hats off and slash away with the razor blades. That's how they got their names.
You might need that by the end of this podcast.
Lovely. Well, hope everyone's enjoying their coffee.
Now, on that happy note, reintroduce yourself, David, because if people missed the first episode, just tell them about your background. And obviously, you're a KOL for a company called Everless, and you know a lot about lots of toxins, to be fair. But just tell everyone about your background, especially with toxins.
Okay, so I did a dermatology internship in the UK before going into general practice with a special interest in derm. And then 28 years ago, I was trained by a Canadian ophthalmologist to use toxin cosmetically by the name of Jean Carruthers. So I was very lucky to be trained by the grandmother of toxins. Very evidence-based. I've done clinical studies on 7 different toxins and used 5 different toxins commercially in my patients. And I've also been a KOL for Allergan, for Mertz, and for Everless, as you said. I've got a practice in Birmingham called Medizen, which celebrated its 25th anniversary last year. And I also travel widely on a global basis, teaching and training about my passion, which is toxins in all their forms, their pros, their cons, the evidence behind them, and putting to bed the myths and the magic of the differences and the similarities between the toxins. But for me, toxins is my first love. It was my introduction to aesthetics, and I love keeping myself sharp by speaking to colleagues and being challenged.
Okay, so maybe let's take maybe 1,000 sort of foot view of the situation when it comes to toxins. So what do you think has been the biggest change in your understanding of how toxins work now from when you first started?
Well, I think the biochemistry, the pharmacology, the therapeutics is fairly well understood, and we understood that pretty much from the beginning. But what we didn't appreciate back then is the way the differences in manufacture and purification and filtration and desiccation and rehydration can change the behavior of the individual toxins. So I think it's less about the biochemistry of how the products work, but it's also about understanding the variations in the toxins and how those can be used to your advantage. As far as I'm concerned, all the toxins are good. They all work. They all do exactly the same job. They snip some proteins which are part of the snare complex, and they stop the nerve talking to the muscle or whatever else it's joined to. For example, it might be the sweat gland in treatment of hyperhidrosis. But what we understand much better now is how to use the differences to create the effects that we want. A toxin, for example, might spread more just because of the way it's manufactured and purified. That makes it great for a field effect, like getting a nice smooth forehead or treating, say, hyperhidrosis. But if you're doing advanced lower facial work, where you want to minimize the risk of toxin spread, you might choose a different toxin, a different dilution. And by playing around with the toxins, with something called the 6Ds, which I hope I'll be referring to later, you can make pretty much any toxin behave like any other if you understand the basic principles of toxin pharmacology.
So take us back 28 years ago. Who was there? Where were you trained with Jean and Alistair? What did you learn on the day? And when you look back on it, did it seem ridiculous to what we know now?
Well, it did. I believe it or not, I was actually working for a laser company in Birmingham 29 years ago, and I was treating birthmarks and tattoos and broken veins with a copper bromide laser, which used to heat the room to 50 degrees, and I used to wish I was wearing my mankini during treatment protocols. But thankfully, political correctness prevented that, but also technology moved on. But I met a guy who was working for a little-known company called Allergan, who was selling me chemical peels, and I had a training day on, I think it was the MD Forte range. And he said, "You'll never guess what those crazy Americans are doing. They're actually injecting botulism into each other's faces." And I went, "No, I don't believe you." And then 6 months later, I had an invitation to go down to London for the visit of Jean and Alistair Carruthers. And I got to meet them. And we had a whole day's training on the use of botulinum toxins. In particular, it was Botox back then, because that was really the only one that had a cosmetic license and had pretty much 90% of all the studies. So I learned how to inject glabellas and crow's feet and foreheads. And that's pretty much all we did back then for several years. So, yeah, I think I was probably the fourth doctor in the UK to use it cosmetically. And back then it was something you just didn't talk about. Now we talk quite openly. People say, "Well, what do you do for a living?" Well, I'm a cosmetic doctor and I inject toxins and fillers and use lasers. But back then it was like, well, Official Secrets Act, or you really don't want to know what I'm doing in my working day. So back then, no one talked about it. It was all a bit hush-hush, and it was a little bit, secretive. But now, thanks to the millennials and also the wider acceptance of the benefits of toxin, the understanding of the safety, we are seeing people talking about it much more. So I think public acceptance has grown hugely, but also now we understand how to use toxins and minimize the side effects, which we're going to be talking about at a later time, means that my practice has definitely changed hugely. I get far fewer side effects. I get far more happy patients, and also I can use the subtleties of what I've learned to create almost perfect effects. And I say almost because no one is infallible.
So can you walk us through like what your standard consultation process looks like, and perhaps maybe highlight some of the things that you've changed as you've evolved as a practitioner over time to sort of reduce complications and, dissatisfaction and all that kind of stuff?
Yeah, I think if you explain something before you do the treatment and you highlight the benefits and the risks, and you don't give the patient what they expected, then they've signed a consent form, they've listened to the consultation, and they're generally much more forgiving if it's not quite what they expected. But if you then try to explain it after the event, well, that's an excuse. So for me, the consultation is key to managing expectations. And that's why in the UK we have a particular problem. I know in Australia and most other civilized countries, it's only prescribers that are allowed to inject. And in most countries, those prescribers have to have a medical qualification. But in the UK, we still have beauty therapists, nail technicians, budding chefs, cleaners, dental hygienists, all injecting toxin quite legally. And this is the problem, is they go on a one-day course, they say, I'm now qualified. They're not. They've got a certificate, but they didn't spend that one day learning psychiatry, psychology, anatomy, biochemistry, pharmacology, therapeutics, etc. So for me, I am a doctor first and foremost. And a doctor's consultation, it's past medical history, it's social history, it's what medication they may be on. It's about whether they have any underlying conditions, pregnancy, breastfeeding, anything that may preclude the use of toxin or make it more likely that they have a side effect. So I'm duty-bound to do what's best for my patient, not what's best for my bank account. So my consultation is always a minimum of half an hour, preferably 45 minutes, even for something as perceived simple, such as toxin, because I want to keep that patient. And I find that by developing a relationship with the patient during the consultation process, then they trust me. And I think trust is a hugely important thing, rather than just cramming as many patients into your clinic as possible, because it's a lot easier to keep existing patients than it is to keep finding new ones. So for me, it's about getting to know them, their drive. I mean, are they having a toxin injection because they've just separated, or they've lost their job, or they're divorced? Straight away, those are red flags. Well, toxin's not going to make you any happier. So the reasons for considering it, their understanding of it. People still say, I want some toxin in my lips, or I want some filler in my frown lines, because they're interchangeable. So it's all about education. And then listing the side effects, listing the potential risks, the likelihood of those side effects occurring, and also the importance of a consent form and photography before and after treatment, and also making sure that the appointment's in the diary for review of the patient, because most patients are very, very happy with the result. But some of the patients, when they come back, and I'm sure we've all experienced this, they say, well, I'm not convinced it's made a big difference, because they don't remember how they looked. If you can then take the after photos and then pull the before and afters up on the screen, the reaction is almost universally, oh my word, I had no idea that I looked that bad 2 weeks ago. So for me, the 2-week review is critical, not only to reinforcing the patient's understanding of how effective the treatment has been, but also it greatly improves retention, because they know that you've actually made a difference. And that follow-up appointment is also an opportunity to explain the importance of regular treatment. So for me, the actual injection is the shortest and quickest part of the patient's experience within my clinic.
Yeah. Two particular areas within the consult that we often hear people struggle with is, number one, when you have to have a patient come back and do a dose adjustment where you might have, not got the result that you wanted, and do they pay for this, do they not pay for this, and obviously discussing it ahead of time is important, so I want to get into that. And the second thing is being able to take control of that conversation, especially for those younger patients potentially that are very educated, they know exactly what they want. How do you kind of transition that conversation back into, well, you're the expert, you're the one that's going to be telling them what you think they need, and how do you sort of handle those two delicate situations where, a lot of injectors struggle?
Okay. Well, I'll address the second point first, because I find this quite interesting. Inevitably, you do get people who've been to the University of Facebook, or they've been on TikTok, they've seen videos by people who like to think they know what they're talking about. So rather than conflicting with the patient and arguing them or correcting them, I actually raise the game and I start playing their own game back to them. So if they start talking about the actions of the toxin, I'll start dropping things like a vesicle-associated membrane proteins and synaptosome-associated protein of 25 kilodaltons and the effect on the neuromuscular junction. And straight away you can see their eyes glazing over and they're thinking, oh, crikey, this guy knows his stuff. He knows more about it than me. And I can start quoting papers. Well, obviously, you've done your research, so you'll be familiar with the Perchik paper of late last year, which clearly details the differences in the toxins effects using myographic measurements to assess the movement of the skin before and after toxin application. And some of them are flattered by this, and others go, okay, fine, you call my bluff. All right, I'll settle down. I'll listen to what you're going to tell me. So rather than just telling them they're wrong, I just play them at their own game. And usually they get the message very clearly. So I prepare them at that first consultation. I'll say, look, if you're naive to toxin, you've never had toxin before, I know what the average dose will do for the average patient. But there is no such thing as an average patient. In the same way that if you go into a dress shop and say, I want that one in the window in a size 10 or a size 14 or whatever, the chances of it fitting every curve perfectly are remote. So if you're going to have a dress that fits every curve, you go to a dressmaker. Think of having your wedding dress fitted or having your wedding groom suit fitted. You'll go back for a second and maybe even a third fitting because you want it to be perfect. So I say to the patient, look, I am going to use my best guess. And my best guess is based upon nearly 30 years of experience and tens of thousands of patients. But if my best guess is not right, we're going to bring you back in 2 weeks anyway. And if we need to do any tweaking, that to me counts as, if you like, the second fitting. It's all included in the pricing. I'm not going to charge you extra just because I didn't get the calculations just right. It's all part of the service. And that's the way I sell it. It's all about the first treatment is the test dose. We don't want to overdo it. I could always put more in, but I can't take it out if we put too much in. The patients really love that because many of them are still a little bit nervous about their first experience, and they may have had friends who've had a mephisto, or they've had a droopy eyelid or a brow ptosis or whatever. So actually preempting their concerns and raising them before they do, I think is key to a successful consultation, and again, key to those patients coming back. Because if I don't call them back in 2 weeks, a percentage of them will go, well, actually, I paid £350 for that or whatever it might be. I can't really see a difference. And it's not until they've seen the before and after photos, they realize the difference you've made. So you don't know what you looked like 2 weeks ago.
Yeah, David and I have discussed the commercial side of this because you've been here to Australia, David, and I've obviously worked in the UK. Toxins are much cheaper to buy for us practitioners in the UK. And so I think that, if someone needs a dose adjustment in 2 weeks' time, I don't really think it sort of affects your commercials in any way to do a few more units. Whereas here in Australia, depending on how wrong you have been in your first treatment and you need to do a dose adjustment, if someone effectively needs double the dose, you won't be able to afford that in Australia. So you shouldn't be that far off, obviously. But, a couple of units here and there, I think that would be fair enough to, complementarily do 1 or 2 units. But anything more than that, depending on where you are in the world, you need to make sure that makes business sense.
I think it's kind of nuanced. I think it depends on your business model as well. If you're someone that's a higher price point practitioner, you've got heaps of margin in your product, then you probably would, be inclined to include that in your overall price because you're charging a premium service. Whereas if you're, maybe like a high street kind of clinic, or you're in a more, high volume, lower margin business, then there's things that you can do to sort of circumvent that if you don't want to include it in the price. We've spoken about it before, but, as you kind of said, David, we're going to be conservative. This is my best guess. I'm not going to charge you for the units that you might not need today because you'll hate me if I overdo it. But when you come back for your review, if you need more units for your dose adjustment, I can charge you then. But I think it depends on your business model, really. Yeah. I don't think there's a right or a wrong.
If I sound stingy, it's because we know that a lot of our listeners are doing free dose adjustments forever.
Well, it's a problem because, sometimes it shouldn't be like a regular occurrence. You shouldn't be having many of these. So, but sometimes you almost train the patient to expect if it's not absolutely perfect, then you're just going to continue to fix it for free. So for some people, it can become a slippery slope commercially, and they start programming their patients to expect it.
Yeah.
But yeah, I don't think. Yeah, it's nuanced.
Yeah, I would agree with that. And certainly what I try and dissuade is those patients who come back 3, 4, 5, 6 weeks later saying, oh, it wasn't quite as good this time. Can I just have a top up? And it's those patients that you need to be very careful in managing. And it's very much about, well, we top you up at 2 weeks if necessary, but once we've done that the first time, we've set your dosage. And if anything, as time goes by, you'll probably need a lower dose because the muscles have become smaller, they've debulked, so we shouldn't need to keep topping it up. But also, we don't want to keep topping you up because there is a suggestion that this could lead to the increased risk of you becoming immune to the product and therefore it not working at all. And we don't want that, do we? So, the persistent requests for top-ups, particularly 4, 5, 6 weeks later, I know exactly what game they're playing, and I think I would agree they're certainly not getting free top-ups every time.
Yeah. Do you agree that we're using toxins routinely now off-label? So lower face, mentalis, DAOs, calves, traps all over the place. Do you think we're becoming too rogue as a specialty? Do you think we're too loose compared to other medical specialties when it comes to using off-label medicines?
The thing is, what we have here, we have an incredibly safe drug. If you double the daily dose of paracetamol, you can kill someone. If you double the dose of warfarin or digoxin or whatever, you can do serious damage. To do harm with say, Botox, because the data's there, you probably need about 100 unit vials injected intraperitoneally to do any damage. So it's not going to do any serious damage. So that's the first important thing. But secondly, those of us who have been injecting...
Well, damage your bank account.
Yes, true. I say to a patient, if they're worried about it, I say, look, this is one of the most toxic substances known to man, but toxin is dependent upon dose. You can kill yourself with water if you drink enough of it, but you couldn't afford an overdose of toxin unless you sold your car or probably your house. So it's that safe. But going back to the duration I've been in this industry, nearly 30 years, when I first started injecting, pretty much everything was off-label. It had a glabella license after I started injecting the toxin. So more licenses are appearing than Allergan have got glabella and crow's feet and frontalis and masseter and platysma and so on and so forth. And of course, they've had a migraine license for a long time and hyperhidrosis. So I think rather than waiting for the license to come out for the mentalis or the DAO or whatever, what we need to be focusing on, rather than being perceived as rogue, is making sure we understand exactly where our needle tip is. And certainly a lot of the companies have really been pushing the opportunity to attend anatomy masterclasses, hands-on dissection, and using mannequins to practice injection technique with either color changes or electric buzzers or whatever. And I think ultimately it's more important that your technique is correct and your injection location is correct rather than worrying about whether you've actually got a license for treatment of nasalis. And to be honest, the cost of doing a clinical study to get an extra license for minor areas where you're only going to be putting 4, 5, 6 units in, I think it would just be untenable.
So just to be clear, you're not doing scrotum tox in your practice, David?
Well, I'm not. I have been asked. But I don't know, it's just something that it wouldn't make me want to get out of bed in the morning, should we say.
I guess my question was, we've learnt off the back of the Gene Carruthers, the Michael Caines, they were doing all this stuff that at the time they had no idea what would happen until they tried, right? So, we've learnt off the back of all these giants and yourself included. So, yeah, I guess how do we teach off-label when pharma don't teach off-label? That's really my question. And that's why people like injectors are learning off Instagram and TikTok and YouTube, because it's not easily available information, is it? So how do you recommend people do learn off-label treatments if they can't be taught formally?
Yeah. You see, that's the thing, is the pharmaceutical companies can only teach on license. And this is one of the frustrations when particularly you have a new toxin launched, as I know in Australia over the last 2 years, you've had 2, 3, or possibly even 4 toxins launched. And each one of them starts off with a glabella license. And you're launching a new toxin, a competitor to what's tried and tested, and all you can do is train on the 5-site glabella injection technique. Now, who is realistically going to take a half a day or a day out of their busy, lucrative practice to learn how to inject yet another toxin in exactly the same way? So that model just does not work. But the problem is, because all this training is perceived to be free, then if you actually ask a delegate to say, well, look, you can come on an advanced toxin workshop. It can't be sponsored by the drug company because it's off license. Therefore, you'll have to self-fund it. They go, oh, hang on, how much is that going to cost me? And I will say, well, £1,000 a delegate or £2,000 or whatever it might be, small group, 5 or 6 delegates. Oh, that's a lot of money. And I'm thinking, well, the upskilling that you're going to get from a training session like this is going to transform your business. But people are so used to having things for free, sponsored training provided by the company who wants you to switch to their filler or skin hydrating agent or topical skincare or whatever. So actually charging people to upskill with a new toxin actually does generate quite a lot of resistance. And that's why I tend to focus a lot more on the science rather than just saying, well, let's train you up in yet another toxin. Understand why the toxins are different and choose the toxin most appropriate to your skill level and your practice and also your patient expectations, because we've all got different types of patients.
So how would you recommend a injector that's looking to find their go-to toxin? Like, what kind of, process would you go through in sort of selecting, you said what's best for their patients, what's going to be more difficult or easy to use? Like, can you sort of give us an idea of what that might look like?
Well, as I mentioned earlier, there is no such thing as a bad toxin. But we also all know, those of us who've used more than 1 or 2 toxins, they all have their individual little niceties. Some of them seem to spread a little bit more. Some of them seem to kick in a little bit quicker. Some of them seem to last a little bit longer. So there's many, many variables. And I use my 6D technique, which is first of all about the choice of drug. Which toxin do you use? And ultimately, some injectors find that they like a toxin that spreads, because wherever they inject it, it's going to hit something. I know it's a little bit simplistic, but we know that if you use a product with a smaller molecular weight, for example, Dysport, Azido, Illusians, etc., we know that they spread more. And arguably, that's a benefit in certain conditions. You get a nice, smooth, shiny forehead. You get better results in hyperhidrosis, even if it's off license. But if you're using a toxin like that, say in the lower face, where you want to accurately hit DAO and avoid DLI, or hit mentalis and not hit other muscles, and if you want to treat masseter without hitting risorius, you do not want that toxin to spread. So choice of drug is really dependent upon, do you want a shotgun or do you want to use a sniper rifle? So I actually carry more than 1 toxin in my practice because I want a toxin that spreads more. But by using my 6Ds, first is choice of drug, secondly is dose, how many units. We know that 1 unit of Botox is not exactly equivalent to 1 unit of, say, Xeomin, Bocuture, is not exactly equal to 1 unit of Nuceiva or Latiba, or indeed any others. They've all got their little niceties. So the dose in units is important. The dilution, how much volume you add, the bigger the volume, the more spread you get, which is why we use a dilution in axillary hyperhidrosis to encourage spread. That's another reason why I don't like the ready diluted toxins, because the company has very thoughtfully said, well, we've taken all the calculations out. You don't even need to think, because we've done all the hard work for you. You don't need to worry about calculating the units you're going to use in a patient. I'm really sorry. I'm a doctor. I went to medical school for 5 years. I did manage to get my O-level maths. I can work out units and volume. But what I don't want is someone to say, right, we've already diluted the product to a weaker, more voluminous solution than what I want to use, particularly in a toxin that tends to have the characteristic of an increased field of effect. So I don't want to use a toxin that someone has made up for me and ready diluted it. And secondly, because those toxins are made up with normal saline rather than preserved saline, they definitely sting more. And there's countless studies have shown that the pain from the pre-made toxins significantly greater. Now, my patients do not like that. They're used to relatively painless injection. I use 31, 32 gauge needles. I use preserved saline. They're used to it being a 1 or a 2 out of 10. If I switch to a toxin and suddenly they feel like they're being attacked by a swarm of bees, they're not going to like it. Arthur Swift once said to me years ago, I love the phrase, he said, if you pain them, you don't retain them. And for me, I don't want to hurt my patients. So That's important to me, the dilution. The depth of injection, that's critical because understanding three-dimensional anatomy, it's not like a treasure map. So yes, on the image of the face, the muscles are drawn on the picture, but what it doesn't tell you is how deep they are. So how far through the skin do you push your needle? How thick is the skin? Which muscle do you hit first? How thick is that muscle? So depth of injection, direction, if you're going at an angle, that needle will end up not underneath the anatomical marking point. And also delivery, how fast you inject. If you inject very quickly, you're going to squirt the product out of the end of that fine needle and it'll find a tissue plane, increasing the risks of mephisto and droopy eyelids and scary eyebrows and all sorts. So delivery in gentle injection technique. So ultimately, you need to find a toxin that all those 6 Ds work for. And I think the problem is if you're changing your toxin, which is something I could go on forever about, is it's very easy to switch, for example, say from Botox or Xeomin to Nuceiva or vice versa, because they're all roughly one-to-one and they all roughly have a similar degree of spread. But if you're changing from Dysport to Lusiance to, say, Botox or Nuceiva, then the product behaves differently. And unless you make allowances in terms of volume of injection, number of injections, site of injections, depth of injections, you won't get the same predictable results. So it's important to understand that any toxin can be made to behave like any other if you play around with your technique and your dilution. But you need to understand the toxin that you choose. And no one toxin, in my opinion, is suitable for everything and everyone.
That's a great summary. I'm going to test you on the 6 Ds later,
Well, I wasn't sure. Did we get all of them? You've got drug, dosage, depth, dilution, delivery. Was there one more missing that I...
Direction.
Direction. Sorry, yes.
There you go.
Wrong direction.
We should add David. Yeah, 7th as well. Now, we're going to talk about, I guess, aftercare stuff that we traditionally tell our patients of what not to do to try and avoid complications. Now, I keep my advice to patients very simple, but I'm curious to know what you say. But, if you open the box of most of the toxins, they'll say some standard things. So don't lean forwards for 4 hours. Don't lie down for 4 hours. Don't massage or rub the areas that are treated. How relevant is that information in 2026?
Right. So there's lots of studies out there which suggest that 90% plus of the toxin binding to the membrane is all over and done with within 4 hours. So anything after that is probably not going to make a huge difference. But there is an element of truth in some of the advice. For example, if you touch or rub the treated area before the toxin is locked in, arguably you could move it. Secondly, if you have nicked a little blood vessel, then massaging or rubbing the area could increase the amount of bruising. Alcohol, we know alcohol is a vasodilator. So if you drink before the injections or drink in the evening after the injections, it might slightly increase the blood flow to the area and may slightly increase the risk of bruising. I don't think it'll have an effect on toxin spread. So half jokingly, half seriously, I say to my patients, look, I'd rather you take it easy tonight. Okay, you've had your injection today. Don't go to the gym because you'll start mopping your brow. But if you try and fall asleep on your back, it'll take ages unless that's your normal position. And when you finally do fall asleep, you're going to roll over into your normal decubitus. So all this about not lying down and that is nonsense. So I don't advise them not to lean forwards. I don't advise them not to lie down. But I say, look, don't have a heavy night tonight. Preferably don't have a heavy morning before you come and see me. And don't massage or rub the treated area. But if you want to go bungee jumping tomorrow, that's absolutely fine by me.
That's exactly what I say to people. I don't include bungee jumping in there, but I basically say...
I was trying to be a bit antipody in there, but I think that's your neighbours, isn't it?
Yeah, basically from tomorrow you're good to go, but today just be a little bit conservative and you should be fine.
Don't get a shiatsu massage on your face.
Yeah, that's a good point. When would you let your patients go and have a facial massage after Botox or a toxin?
I would say 24 hours later. 24 hours as far as I'm concerned, even if they're lying down and they got their face in one of those holes in one of those massage benches. There's no evidence that any more than 24 hours aftercare is necessary.
Yeah, I've still got patients, new patients who come and they said, my other injector wouldn't let me do anything for 2 weeks. So, there's still people telling people don't breathe, don't walk, don't do anything for 2 weeks, which, fair enough, but it's not really following the science.
Yeah, and that's actually based on something anecdotally. There's a British journalist, Lynn Franks, and she used to write for The Guardian. And she was on that I'm a Celebrity program about 15 years ago, and she was the one who kept faking faints when she had to eat the bugs. And she was one of the first journalists to have toxin treatment, and she had it done in the US. And then she flew home and then developed ptosis. And she phoned her injector in the US and said, something funny's happened to my eyebrow, it's dropped down. But he said, where are you phoning from? And she said, well, I'm back home in England now. And he said, what? You got on an aeroplane? Within 7 days of having treatment? Oh, you shouldn't have done that. Oh, that's what's done it. She then wrote about it. So it's an urban myth that was perpetuated by a relatively credible, and I say relatively, credible newspaper. And that's where the myth has stuck. And it was basically the injector trying to shift the blame onto the patient rather than accepting that they'd put the toxin in the wrong place and created an adverse event.
Yeah, fair enough.
There you go. That's the origin story right there.
Yeah. I mean, how much do you think patients have in terms of influencing their risk of a complication after they go home? How likely is it that they caused it rather than the injector?
I think it's highly unlikely that the patient has had sufficient effect on the toxin to make a side effect occur. I think 9 times out of 10, you've put the product in the wrong place, or you've chosen the wrong product for the indication. And I think there's too many injectors are looking to shift the blame. My view is, on the rare occasion that you do get a problem, mea culpa, okay? We did talk about this. It could happen. You've been very unfortunate. Don't worry, it'll wear off. I can do this to help you through it. And that's what patients want to hear. They want to know that their doctor or injector cares for them. They want to know they can help them through what may be a challenging time, particularly if it's a cosmetic problem like a ptosis or whatever. But they want their doctor or prescribing injector to be a health professional. So I'm not a firm believer in making excuses. Own the problem. I don't think someone going and having a massage 3 days later and getting a ptosis can be blamed on them. It's my fault.
Yeah, fair.
What's your advice these days on breastfeeding, women that are pregnant? Is it still the same, as much change there?
Yeah, the thing is, the studies have been done in women who are still lactating but are no longer feeding. So they injected them with cosmetic doses of botulinum toxin and then took samples of the milk via breast pump for several days after the injection. And in 50% of the samples, they found tiny, tiny traces of toxin. And it's likely that during the injection process got into the bloodstream and was mega diluted within the circulatory system, and a tiny amount got through into the glandular tissue. But this is way, way, way below what would be considered a hazardous dose for a child. And we know that the toxin is used in 2-year-olds in much higher doses than cosmetically to treat spasms caused by cerebral palsy and the like. But ethically, if you did inject someone you knew to be pregnant or breastfeeding and something happened, that child, developed meningitis or became dyslexic or showed signs of ADHD or autism, in the same way we had that scandal with the MMR vaccine, people are always looking for a blame. So my view is, if someone is pregnant or trying to get pregnant, I don't treat them. If someone is breastfeeding, unless they have stopped feeding, I will not treat them. I know in America there's this thing called pump and dump. So what they do is they actually express the milk before treatment, save some of that for the baby, and then for a week afterwards they pump the breast milk and then dump it. That all sounds a bit bizarre to me, but I certainly wouldn't be treating someone until they'd finished the breastfeeding, because I just want to sleep easy in my bed at night, even though there's no evidence of harm. In terms of the pregnancy question, we know that a lot of the patients we're treating are of reproductive age, and that toxin's in their system for 3 or 4 months. And sometimes patients, you won't see them for a year or more, and you think you've lost them, and they come back and say, oh, sorry, I dropped twins last month, but now I've got to get these wrinkles sorted. So they had the toxin in their system when they got pregnant. And again, there's absolutely no evidence of any harm. And we believe that's because once the toxin is locked in that muscle, that is not going to travel anywhere, not going to get into circulation, not going to get through the placental circulation. So if someone has had toxin and then found out they're pregnant, I reassure them completely. But if I know they're pregnant, I won't treat them.
I'm sure every injector's had this same kind of scenario. So I had a patient just a few weeks ago. She knows that she's going to embark on IVF at some point in the next 4 to 6 months. And she's trying to get very sort of, clever with her timing of when can she have her last Botox and then when should she stop. And my personal attitude is once you've flagged to me you're going to try for babies soon, well, this is your last time I'm going to see you. And, if it's in 1 month time that you're going to try, we won't do it today. But if it's going to be in at least 4 months' time, then fair enough, this will be your last treatment. And then it's kind of on the patient to abide by what you've told them, right? They shouldn't be starting to try for a baby the next day. But we can't be very black and white with that information either. It's up to the patient to sort of listen to what we're trying to explain to them without any hard and fast rules.
Yeah, I'd agree. And we can only advise. And thankfully, we're using a product where there is no evidence of harm, both in pregnancy and breastfeeding, but we are duty-bound to be doing the best for our patient, but also to be seen to be doing the best for our patient, which is why medical record keeping is so important, and a detailed consent form specifically confirming, I certify that I am not pregnant, I certify I'm not breastfeeding. That way you are demonstrating best practice at all times.
Yeah. Now, you mentioned pain and bruising. Let's talk about that briefly. So these are probably the most common, if you like, complications of a treatment, discomfort, and the most obvious thing that patients worry about is bruising.
I mean, complication versus effect, side effect, everything. So what's the difference between a side effect and an adverse complication?
Well, I think a side effect is something that you can reasonably expect to happen and can be considered normal and just unlucky. So bruising. You can't identify every capillary. You should know where the major arteries are in the supratrochlear and supraorbital and so on and so forth. But when it comes to hitting a small vessel, that's just bad luck. And that is not, to me, a significant adverse event or a complication. It's just one of those things that can happen. And the patient needs to understand that, and they usually do. So occasional bruising, I tell the patients, look, if you're going to have filler, you've probably got 10, 15, 20% chance of bruising. If I'm doing toxin properly with a 32 gauge needle, you might have a 1 or 2% chance of bruising, but you've still got a 1 or 2% chance of bruising. And if you're having a full face treatment, then it increases with the number of injections. And if we're then starting to do, for example, platysma, we know that the neck skin is very loosely applied over the platysmal muscle. So if you do hit a vessel, it tends to spread. And I do warn the patient if I am going to do platysmal injections, I say, look, just be aware. You may, in a couple of days' time, look like you've been behind the bike sheds with an old boyfriend. And you look like you've got a hickey on your neck. So just be aware the risk of bruising in the neck is probably slightly higher. And I usually make a bit of a joke of it.
Yeah, no, it's a good point, David. I guess the reason to highlight this is because these are the things that our patients moan about. They're the most obvious things that happen on a day-to-day basis. Ow, he hurt me. He's a terrible injector. Wow, I got a bruise. Dr. Jake's rubbish. This is what our patients think, even though us injectors know it's part and parcel of using, 25 injections in a face. So back to your comment about pain and normal saline versus preserved saline. This is a recycling conversation on Instagram, it seems, that, it's on label to use normal saline with most of the products, as far as I know. I personally use preserved saline. It looks like you use preserved saline. Can you just explain when you changed and why you changed? What is the difference?
I changed 22 years ago when I was speaking to a renowned dermatologist and dermatologic surgeon from South Carolina, a chap called Tim Flynn. And he was doing a masterclass. And he said, why are you using normal saline? And a bit like Arthur Swift with if you pain them, you don't retain them, his attitude was very much, if you bruise them, you lose them. So by using a preserved saline, it's buffered. So it has a small amount of benzyl alcohol in there, which keeps the product at close to physiological pH. So although the needle itself, particularly if it's blunt and it's been through the skin a few times, can cause an unpleasant crunching sensation, particularly if you've touched the bottom of the vial or pushed it through a bung repeatedly, and you blunt the needle. These needles, remember, effectively most of these syringes are designed for insulin, which is a single injection. And the quality of the steel is designed for that needle to go through the skin once. So particularly if you're using the BD needles and syringes with the orange caps, you find after 2 or 3 times going through the skin, you start to feel the crunch, the patient starts to feel the discomfort. So that is something which, if it's a problem, then look at whether you're pushing through the bun. I personally decap all the vials, which I find anecdotally with Nuceiva, it's got a ring pull on it so the bung comes out easily. And secondly, when you're taking the product out of the vial, don't touch the bottom of the vial with the needle. Just hover just above it and be very, very gentle. And that way the needle will slide through the skin nicely. But going back to the preserved saline thing, there's also been some interesting studies looking at potency of toxin and how long it lasts when it's injected after mixing with preserved and non-preserved saline. And there's several studies now that show using the preserved saline keeps the toxin stable and more potent for longer than those who have used non-preserved saline. And some studies have suggested that could be up to a month. Now, obviously, that is well outside the license and the recommendations of all the companies. But what it means is that I can mix up toxin on a Friday, and if I happen to have a vial left over, I can happily use that on the Monday, and I know there's going to be no loss of potency. And the toxin has been with preserved saline, and as a result, it's bacteriostatic. So any risk of contamination, however small, is pretty much negated.
Right. Okay. Interesting. When it comes to bruising, has there been any advancements in techniques or patterns that you're aware of that sort of meaningfully reduce instances of bruising for our patients?
I think application of a cool pack can certainly cause some vasoconstriction, which means that the vessels have shrunk. So when you push the needle through the skin, you're less likely to hit it because it's in vasospasm. So there is an argument with that. But the problem is placing an ice pack on the patient's frontalis or glabella often causes what I call the ice cream brain freeze. So it's actually more distressing and painful than it is pushing the needles through the skin. But that is an option, particularly with some patients who may be a bit squeamish or have a low pain threshold. But that should reduce bruising. I mentioned earlier about avoiding alcohol on the day of the treatment and the evening after, and just to minimize vasodilation. There's little evidence for Arnica. Arnica montana is an alpine plant found pretty much throughout Europe, and an extract of the plant, although toxic when taken orally, can be applied topically or used in very, very low homeopathic doses by mouth. The evidence for efficacy for bruising, swelling, and post-treatment pain is poor at best, although some patients swear by it. So it's not going to do any harm. It might do them some good. And if someone does get a real shiner, for example, you might be doing an infraorbital injection to widen the eye or treat infraorbital creases. If they do get a bruise, then if you do have access to, say, a pulse dye laser or a V-beam or an Excel V Plus or any vascular laser, then cautious use of a laser can speed up the resolution of the bruising. But arnica, I'm not a huge fan of. Ice, if the patient can tolerate it. And there's even these little vibrating devices that you can use, or even the back of an electric toothbrush head. And it activates the slow fibers rather than the fast pain fibers, so it confuses the sensory apparatus and reduces discomfort. But I find most of my patients are more than happy to put up with 2 minutes of mild discomfort, which is rated as a 1 or 2 out of 10, for the results that they get, which will last them 3 or 4 months.
Yeah. So presumably you can put this myth to bed that preserved saline, these stories are going around, it somehow affects the potency or the duration of toxins. I've not seen that. Have you?
Absolutely not. In clinical practice, no. And I know there's lots of noise on the Facebook forums and TikTok and all that. Patients shouting about, since they changed, this has happened. I've searched far and wide for evidence-based clinical publications, etc., and there are publications that have compared it, and there is absolutely no difference whatsoever. And indeed, some of the evidence is In those using preserved saline and with a delayed injection after reconstitution, arguably it may actually last longer because you're maintaining the potency by using the preserved saline.
Yeah. You mentioned already your needle size or your caliber. You're using a 32. Many people here in Australia use a 30, which is the BD. Have you tried the even smaller ones, the 33, the 34? There's a TSK invisible needle.
I have tried the smaller ones, but I tend to find that they go blunt more quickly. But also, because of the narrow bore, you have to actually exert a little bit more pressure to get the toxin through the needle. But also, it's a bit like pinching the end of a hose pipe. If you've got a narrower bore, the product will come out under higher pressure. And therefore, my concern would be that if you're working in an area where there may be a tissue plane or a foramen, like, say, the glabella and the supraorbital foramen in particular, I wouldn't want that product to be forced into a tissue plane and increase the risk of adverse events of brow or lid ptosis. So I think 32 is a happy medium for me.
Yeah. Is there a particular brand that you like of needle?
I use I think it's the FMC ones.
Yeah.
FMS, I'm using those as well.
Yeah, FMS.
Or
FMS, yeah.
FMS, yeah. Okay, perfect.
Yes,
Very
FMC
nice.
is one of my favourite wines. It's from South Africa. It stands for something magic shina.
Yeah. So, when it comes to, I guess, very rare potential side effects or complications, in some of the sort of the PI or the product leaflets, there's things about, heart arrhythmia, heart attacks, things like that. Have you ever sort of seen or heard any of that?
No, again, I have looked widely because I'm always asked this question when I'm doing a complications presentation. Well, I knew someone who had toxin and then 3 days later they had a heart attack and died. Well, kind of that's situational. There is absolutely no logic with something that is injected locally and has minimal to zero systemic spread that could possibly have an effect that might lead to, say, stroke or heart attack. You're far more likely to get that with erroneous placement of a filler. I mean, I suppose one could argue if you injected something directly intraarterially, there could be an osmotic effect, there could be a vasospasm, but that's going to happen probably in the cerebral circulation. It certainly won't happen in the cardiac circulation. So there is really no evidence of cosmetic doses of toxin having any catastrophic effects or leading directly to fatal events. I think it's purely chance and purely situational. So I don't believe it's a risk.
So to follow on from that, you may have come across these big Facebook forums or other sort of private forums of patients where they swear blind that they had a toxin one day of any brand. It's not a particular brand that's associated. And then they're claiming they've got all these chronic problems, chronic fatigue, malaise, it's caused some sort of systemic issue with them. And there's patients convinced that toxins are evil, effectively. Have you heard of this type of phenomenon? There seems to be thousands of people talking about this stuff.
I've seen these forums. I've seen websites. I've seen posts. But what's interesting is none of them, not a single one, is evidence-based. None of it is based upon clinical studies, retrospective data, prospective studies. These are all patients' experiences. And the thing is, this is what we find. If you eat at a bad restaurant, you'll complain about it. If you can't get an appointment with your doctor, you'll complain about it. But the people who are happy generally don't shout. So there is an argument that if you're having massive doses of toxins to treat systemic muscles, like you might in cerebral palsy, Parkinson's spasm, disseminated sclerosis or whatever, inevitably you are giving significantly higher doses. But bearing in mind that a 2-year-old child could potentially have 200, 300, 400 units of toxin, I absolutely refuse to believe that 20 units of toxin in a glabella is going to have long-standing systemic effects. The product itself is gone from the body in 4 months. If you radiolabel it, it's gone. It's a protein. It binds irreversibly to the receptor proteins on the membrane. And as those membranes are naturally recycled and disappeared and replaced by new tissues, they're gone. So it doesn't accumulate in the body. So as far as I'm concerned, it's not evidence-based. It's absolute nonsense.
Yeah. I mean, Dave, you and I were talking about this a little while ago, and we said, as doctors, we want to have empathy for anyone who's unwell. And if they claim that their issue is from something that I offer, then it's something for me to at least bear in mind of what they're complaining of, even if I don't believe it. So how do you think we speak to these people? How do we counter it? If someone came to your clinic and said, I'm not having toxins because I've heard about all this stuff online, how would you explained to them in a way that makes sense?
Well, I think part of the issue is that the patients that we see, we do attract an extraordinarily high percentage of patients with psychological issues, vulnerable patients who believe that they somehow are not attractive and they need bigger lips, or they need their almost invisible brow furrows treated. And these to me are red flags. And these patients, as I reflected earlier, need to be gently persuaded not to have treatment, because it's not going to change their life. So inevitably, we are going to attract these patients who are think we're promising them the world, and when they don't get what they thought they were going to get, they become quite introspective. So I think the first skill is learning to say no, identifying these patients who are going to be trouble. If someone comes to me and says, well, look, I've been thinking about it, but I've read all this, and I've been on TikTok, and I've been on Facebook, and I've got a friend who has a friend whose mother died 3 weeks afterwards, I'd say, look, respectfully, I don't think I am the right injector for you. I think with all these concerns, I really don't think this is the right treatment for you, because I'm storing up trouble for myself down the line. So I'll let you into a little secret. I've got a stack of cards of my nearest competition, and I'll just give them the card and say, this guy may be able to help.
Very, very nice.
Fair enough. Now, one rare complication, I've never come across this before we delve into part 2, is the use of aminoglycoside antibiotics. Now, I've never had a patient on these drugs and had this problem, but apparently it can potentiate the effect of toxins and actually make them last or affect more strongly. Have you ever seen that in real life?
Yeah, absolutely. I mean, it's one of the first things we taught when we start using toxins is the contraindication is a patient actively on aminoglycoside antibiotics, because they have a similar effect on the neuromuscular junction. And there is an argument to suggest, well, if you give patients long-term low-dose aminoglycosides, it helps the toxin last longer. Now, for me, the aminoglycosides are not designed for long-term use. They are highly toxic antibiotics. And if you give a patient long-term broad-spectrum aminoglycosides, you're completely messing up their biome, but also the main side effects are things like ototoxicity. You know, you could end up deaf as a result. Nephrotoxicity, you could end up provoking someone in renal failure just to give them 2 or 3 weeks longer with their toxin. To me, that is absolutely unethical and indefensible practice, and I would absolutely shut that down. Anyone on aminoglycosides is not getting a toxin injection from me until their course is finished and they've had a washout period.
Yeah. So have you ever met a patient who accidentally had a toxin on those drugs? Does it sort of last longer or feel heavier?
Not if they've told me the truth on their medical history form, and that medical history form is repeated every time they come to see me. So I absolutely want them to clarify, are you taking any new medication? Have you had a prescription recently? Has your medical history changed? And they sign before they actually sign the consent form proper, because you can never trust a patient. They forget things.
Yeah, fair enough.
Sometimes selectively.
Yeah. So that is the end of part 1. We've kind of gone through all the soft skills, consultation, background, information we give our patients, aftercare, all of that. So if you want to listen to part 2, where we're going to get a bit more technical, talk about actual injecting complications, upper face, lower face, neck, masticatory muscles, all of that good stuff, you have to join us on our new app. There will be a link in our podcast descriptions. Well, thank you, David. We'll see you in part 2 of your episode, but take care and we'll see you next time.
Excellent. Absolute pleasure. Thanks for inviting me.
Thanks, David.
Thanks, David.
We hope you enjoyed that episode, guys. To stay up to date with our latest news and episodes, follow us on Instagram, and we're now on TikTok.
You can also now watch our full video episodes on YouTube and Spotify. So if you like what we do, please give us a like and subscribe. Please also consider joining our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, hints and tips videos, bonus podcast content, and more.
All of our social links, Patreon, and contact information are in the show notes below, and we'll see you in the next episode.